So, let's continue. We have a little bit lack of time. Anna Martling, Professor Anna Martling, surgeon from Karolinska and very active for many years with the European Society of Coloproctology. And you, Anna, will tell us about MRI-guided decisions with rectal cancer.
Okay, so thank you very much for that introduction, and also I would like, of course, to thank Evangelos for inviting me to this meeting. It's really an excellent meeting in a beautiful environment. So I will talk about a bit from a clinical and a surgical point of view about MRI-guided decisions. We all know that for rectal cancer, the development and improvement in both staging and treatment has been tremendous during the last 30, almost 40 years now. And one important tool in the box that made this possible, I would say, is better staging. And it has been important for all the other aspects, really, to be able to develop in that direction that it has gone. Treatment for rectal cancer, as a result of this development, has gone from a single modality treatment to the treatment we have today with a true multidisciplinary management of rectal cancer. And not only the whole treatment is multidisciplinary, but also the surgical procedure today, I would say, is today more multidisciplinary than it was from the beginning, from a standard procedure. And today we have gone from surgery for rectal cancer, like a tight procedure, to now widening our indications and being able to do more, but also actually doing less and being in an organ preserving era. So it's getting more and more complex. I would say the more we know, the more complex and difficult it gets to really give the right treatment to the patients. And the most, I would say, important tool to help us in the multidisciplinary conference today is actually MRI. It's one of the most central components of the MDT conference today. MRI today is used for many purposes. From the beginning, it was mostly used as a prognostic tool and also to judge operability in rectal cancer patients. But nowadays also we identify with MRI the high-risk patients that perhaps needs another treatment before surgery or a more intense follow-up after surgery. It also helps us to identify the low-risk tumors where we could perhaps do less. And of course, it is an important tool for the planning of surgery. It draws the map for our surgical strategy, but also helps us to perhaps schedule surgery at the right time and also to optimize the surgical team. What is getting even more important nowadays, I think, and that where MRI really has gone into a new era, is the reassessment that we also have heard about in the previous session regarding tumor response. Today we don't only do MRI once, we do it perhaps 2 times or 3 times, and to evaluate our treatment decision, but also to perhaps re-plan or schedule our treatment decisions. And also, of course, it is used for follow-up. With the increased use of MRI and the increased purposes, we also use MRI today at different time points. We use it, of course, as a pre-treatment for the initial treatment plan and prognostics, but we also, as I say, increasingly use it for restaging after having given the first part of the treatment operatively to confirm the strategy, are we on the right track, but also perhaps for changing the strategy. And here, as we have heard, the timing of surgery is debated, but also I would say the timing of the second MRI is still debated. And it tends that we at least know that we have to have at least 6 weeks to be able to see any response in the MRI, and we tend now to go to even later time points for evaluation. And in some centers, as at our own, we do it twice. We do a screening MRI at 6 weeks, and if you have started to respond, we then do a second MRI at 12 weeks. If you not respond, you go and proceed to surgery. And also the last time point is, of course, when it's used for for follow-up during the years after a curative resection, for example. So what kind of information do we get from the MRI? Well, the most obvious part is, of course, that MRI gives us the prognostic biomarkers that we use, perhaps most common for scheduling or planning neoadjuvant treatment, but also actually to plan for the timing of surgery. And those prognostic biomarkers is, you're probably all aware of, the extramural growth, but also the distance to the mesorectal fascia, but also the extramural vascular invasion is of importance, and of course also involved lymph nodes in the mesorectum, and that gives us then the possibility to stratify the patients into good patients, perhaps needing only surgery, the more bad patients with an intermediate risk of getting a local recurrence that we are in my country using 5+5 grade for, and the really ugly cases for chemoradiotherapy, or even perhaps in the future the experimental Rapido trial with proper upfront chemotherapy to try to avoid distant metastasis in the future. But MRI doesn't only give us that, it also gives us quite a lot of information for the detailed surgical planning. And that for pre-treatment we get another view of the tumor height. You can compare it with what the surgeon has found when you have examined the patients, the relation to the perineal reflection, but also the relation, of course, to the pelvic floor is an important landmark when planning and individualizing the surgery. Of course, also the information about the potential involvement in other organs is of importance when you plan the surgery, and also to look at the side walls and see if the tumor has extensions to the lateral side walls or towards sacrum. And not at least, a bit challenging part is the involved lateral lymph nodes, and I will come back to that. And in the restaging phase, it gives us information about the tumor response, the wide MRT stage, the regression grades regarding according to MRI, but also the volume change, and with addition of multimodality MRI also if there are any diffusion restrictions. So I would just give you some examples where to illustrate how MRI could help you in tailoring your surgery and help you do a patient-tailored decision-making. The first example is to identify, of course, the low-risk cases, as in this example with the sessile tumor here growing in the mid-rectum. This could be a case, of course, that doesn't need neoadjuvant treatment, that could go to abdominal resection alone, but this could also be a discussion then regarding could this be taken away with TEM if there's a very superficial tumor or an endoscopic procedure. The second is quite opposite then, is of course the very high risk, to identify a very high risk case with an ugly tumor growing very close to and into the mesorectal fascia here, where you would need to discuss should we add on neoadjuvant treatment before surgery? Do we need to take away another organ if it grows into the bladder or into the prostate? Do we need a pelvic accentuation? And when should we schedule for surgery in relation to the neoadjuvant treatment and the timing of MRI? The third case is also something that is increasingly of increasingly interest, is to identify the patients that potentially need upfront proper chemotherapy before surgery, like to prevent, probably it could be, we will see from the Rapido trial, but patients at high risk of getting distant metastasis during follow-up could possibly gain of getting radiotherapy rather before surgery than after. And then MRI is the perfect tool to try to identify, as in this tumor, you can see here where it grows into the vessels like this. The fourth example is of more surgical nature, is to, as I said, to identify the patients that needs an APE for the first, but also that you can also tailor actually the APE to the tumor. Is the tumor growing into the pelvic floor? Is it growing outside the pelvic floor if you need an even wider excision, or could you do just an extra levator, or do you need an ischoanal levator resection, for example? And there MRI is also important and could steer the way we treat the patient. The fifth example here is even the more advanced cases, of course. You have to look at the bony structures and see if the tumor is growing into any bony structure, as in this case, infiltrating the sacrum. And that is, of course, both of importance for neoadjuvant treatment, but also for planning the surgery and getting the right team, and also, not at least, inform the patients about the sequel, or what they can expect from their functional status afterwards. And then in those cases, you could need very extensive resection, and I think this is one of Professor Holm's specimens showing where we have also removed the sacrum en bloc with the tumor. So the sixth example is in tailored estimation is the one perhaps the most challenging today, I would say, is the detection of lateral pelvic lymph nodes that are tumor involved. It is a problem today to identify still nodal disease, even with really good and dedicated MRI pictures and doctors. The reliable detection of nodal metastasis is presently not possible. Size is not a good predictor initially. Size is a bit better predictor when judging response to radiotherapy. What is better to look at is the signal intensity and the border the border is a bit better, and it might be that the fusion MRI here is promising, and also, of course, as in this case, we could sometimes take help from other radiology modalities like CT PET in this. Why is this so important? Well, it is important because if you find lateral lymph nodes at the first assessment, there could be variety of different options for the patient. Should we treat them with only 5+5 gray? Should we get them chemoradiotherapy? Should we give them proper chemotherapy? And of course, should we go for the lymph node at time of surgery? And of course, you can use various combinations of this. And the evidence actually for the best method in this is not yet clear, I would say. And here's just an example of different, perhaps there could be different surgical strategies. This is a patient where it has responded, but it's still quite a large lymph node after chemoradiotherapy. But in this, you can see that the lymph node is almost disappeared. And could ask what we are doing at the moment is if we still see any enlarged lymph nodes more than 5 millimeters after chemoradiotherapy, we try to go for it at the time of surgery. But if it has reduced and is less than 5 millimeters and look fine, we leave it in place at time of surgery. So, and the last but not least, in the assessment, in the era of organ preserver, MRI has become even more important, I would say. It is the single tool that should make the surgeon aware of that this might be a complete response. You could not rely on it totally. You always have to combine it, of course, with the examination, endoscopic, and with the finger to assess a complete response, but it should be a good warning sign or an alert sign for the surgeon to see if this could be a complete response to pick the winners. But then you of course have to wait, even with 5x5 way, to find those complete responders. This is just one example here where you can see a bulky tumor, and then after radiotherapy you can see it's just a black, almost nothing left here, and then you have to examine the patient and see if there is a complete response. And it is not only important for identifying the potential organ preserving patients, it's also a very important tool in the follow-up in a watch and wait program to compare the slides from time to time to find the early recurrence. And what we do is we use a multimodal strategy, so we also combine it with a diffusion-weighted MRI to see, as like in this design, you can see here a restriction in diffusion, indicating that it might be regrowth after watch and wait. So, in summary, MRI in clinical decision making, it is important, it has been, for prognosis and also selection to neoadjuvant therapy. It is today very important, and I think it will also in the future be even more important as a predictive tool and to reassess the response, as we tend to move more and more of our treatment before surgery rather than after surgery. And it makes us possible to change strategies and to tailor during treatment, not only upfront treatment. And of course, it is also still of importance of follow-up, and especially in the watch and wait program, to find early regrowth to be able to salvage the patients. And we get increasingly number, I would say, prognostic and predictive markers from the MRI, and I'm really looking forward. I know that there are a lot of things ongoing here with improvement in techniques, but also combining different modalities. And also in the area of artificial intelligence, I think we will have a future, even more bright future actually for MRI in combination with other tools. So we have a very fast development there. So thank you very much for Before I stop, I also would like the opportunity to invite you all to the NIS meeting, ECP meeting in NIS, where Evangelos is also very much involved in the program, to another beautiful town. It has just opened for registration. You're all well welcome in September.
So thank you, Anna, for this excellent overview with the information what MRI is supposed to give us and for what we can use it. Last 1 second, please. So last week was a big debate in Germany because of the side effect of gadolinium, the contrast medium.
Mm-hmm.
Due to neurologic side effects. So I don't know whether it happened all over Europe, but it was quite an active, information. And so what will we do if we are no more allowed to use gadolinium? Because we used MRIs pretty liberally in the last years, and you said we do it frequently.
Yes.
So what then?
Well, that's a very difficult question, and I can't really. I have to hide behind my surgical glasses here to say that I am not into the development, and that's an interesting. And we haven't had that debate. I'm not aware of that yet, but so you have had it in Denmark as well. That debate.
2 or 3 years ago.
Nothing happened.
I can't remember the details. I'm a surgeon. I'll have to go back. But it was a big debate.
Yes, it was a big campaign even. Well, so let's hope that, but that means we must not use MRIs that liberally as we have done in the past eventually. So questions. Evangelos first.
Let's take implementation number 6.
Yes.
Tumor outside of beyond the TME margins.
Yes.
You have a lymph node, you send the patient for neoadjuvant treatment. There is some improvement, but you are not sure if there is tumor or not left in the lymph node, and you have to decide whether you could do a TME surgery or something beyond TME. we usually ask in the MDT to the patient to have a PET scan. How long must we have to wait after the end of the treatment and ask for a PET scan? Because we mentioned if we do it too early, we will not be elucidated.
I think you have to have a couple of weeks interval, yes. And then you can perform an MRI. That is a very, I mean, it's an interesting and difficult question regarding what you should do with the still enlarged lymph nodes. What we have, as I said, we have a strategy that we have, if they're still enlarged, we go for them. But we have also looked into how our pathological specimen, and only in 1/3 of the cases, they contain cancer cells. So despite the signs that they're still enlarged and have it's only 1/3 we find still find the cancer cells in the lateral lymph nodes with that strategy.
I think it's more important to keep in your mind that if in the beginning the nodes were enlarged and disappeared, so you have to look in the first MRIs, not to forget that. This is much more important in my experience. So, Dr. Stelsner.
And thank you very much for this comprehensive lecture.
But I think there arise problems. The MRI is too sensitive nowadays regarding the lymph nodes. And in my MDT, I am found in a position where I cannot decide about the treatment for my patients, but the radiologist is the one who says, there are lymph nodes, and then the radiotherapist says, okay, we have to give chemoradiation to this patient. If I look at my database, stage 1 has almost disappeared over the years.
It's true. I mean, MRIs. I mean, regarding lymph nodes, it has the lowest specificity and sensitivity. I think the problem within the mesorectum is not that big. It's the lymph nodes without the mesorectum that is the big problem. Otherwise, we don't have to those inside. We might not need to change the strategy that much for. Of course, if it's very close and it's suspicious close to the MRF, it might be something to have into consideration. They discuss it very much. You see how difficult this is.
I think it depends on national guidelines. The German guidelines say if it is stage 3, if there are lymph nodes, then you have to give neoadjuvant therapy. So that is
we look very much the relation to the MRF then, I mean, in that case, but otherwise we don't bother that much about them. We bother more about those on the lateral side walls.
Well, in other countries, enlarged lymph nodes no more indicate neoadjuvant therapy. So, final question, please.
Yes, you told us your strategy.
Please use the mic.
You told us your strategy at Karolinska. When you use with MRI, I mean, when you use the chemoradiation, the long course. In case you use the short course with delayed surgery purpose, what do? Do you MRI?
Yes.
At what interval?
Yes, we do a new MRI at 6 weeks as well. So 6 weeks after the end of radiotherapy, we do an MRI also with short course radiotherapy. And then we have the same strategy. If they have started to respond, and if they are complete responders, we offer them a watch and wait protocol. If they have started to respond at 6 weeks, we then do another MRI at 12 weeks, and then decide. If they are a poor responder or you have a mixed response, they go immediately to surgery after 6 weeks.
Romano, the very last question.
Yes, I mean, it's a general question. I mean, the first thing is a comment about the nodes. We don't give any importance to the node unless they involve the mesorectal fascia, and even in that case, when the problem is to convince the medical oncologist that this patient should not have necessarily neoadjuvant treatment. And the second question is related to that, and to the previous session actually. I feel that we must give more importance to surgery in some cases, because we have switched from an era in which surgery was the mainstay, then radiotherapy, and then we must go back now and select patient for surgery only. I mean, Q2 cancer, T2 cancer, T3A and B cancer, with sub-stage of MRI, which is a powerful tool to them. I think that this patient should go to surgery. We should go back to surgery. because the side effects that we have seen, the late side effects of radiotherapy, are really important in this patient. And unless the tumor is very low in the perineum, beyond the anterior section, I can see no need to delay with neoadjuvant therapy. And so we don't think enough about surgery. We should go back and select the patient. We now have the tool to do that.
Yeah, and I mean, in that setting, the MRI is extremely important. But you're absolutely right. We have that's the tricky case. On the one hand, we go for organs with preserving an irradiate, even earlier tumor. On the other hand, we could possibly avoid chemoradiotherapy in those cases, or radiotherapy, and go straight for surgery. And we need better tools. We need MRI, but we perhaps need...
Yes, but we now speak about giving radiotherapy even in T1 tumor.
Yeah.
And so that is a contradiction that we must...
It is. That's the rectal dilemma, I would say.
Well, but this is not a matter of MRI. This is a separate discussion.
Yes.
So, thank you very much. And